The general surgery consultant viva is an exercise in extreme pressure. You are graded not just on what you know, but how decisively you act. The examiner begins with a strict clinical prompt. You are presented with Ali, a 30-year-old male with a history of heavy smoking. He has just arrived in the emergency room complaining of a sudden onset of severe upper abdominal pain, accompanied by vomiting. On physical examination, his abdomen is entirely rigid, a classic board-like presentation. The objective data confirms the severity. A plain X-ray reveals air under the diaphragm, and his white blood cell count is highly elevated at 22,000. These findings reflect the underlying physiology. The free air signifies pneumoperitoneum, the rigidity confirms chemical peritonitis, and the leukocytosis represents a systemic inflammatory response. To demonstrate clinical thoroughness to the examiner, you must quickly state your differential diagnosis. This includes ischemic bowel, perforated diverticulitis, and a perforated peptic ulcer. However, given the sudden onset, the patient's young age, and his smoking history, the definitive expected diagnosis here is a perforated duodenal ulcer. With the diagnosis established, the focus of the viva shifts to the execution of an immediate algorithmic operative protocol. The examiner transitions to their first active operative question. What is your preoperative preparation? Looking at the grading rubric, you secure full marks by listing consent, NPO, a nasogastric tube, and intravenous fluids. Aggressive fluid resuscitation is necessary prior to incision. That 22,000 white blood cell count reflects severe volume depletion that must be corrected to prevent cardiovascular collapse. The examiner asks their next operational question. What is your surgical decision? The rubric awards maximum points for stating either a laparotomy or laparoscopic exploration. This shows the board allows flexibility in your surgical approach. If you outline an open laparotomy, you must vocalize your precise entry point, an upper midline incision. This is the correct anatomical answer because it provides the most rapid access and optimal exposure to the foregut where the pathology is located. Scoring full marks in this initial phase requires demonstrating that you can balance administrative completeness, like consent, with rapid physiological stabilization before knife to skin. Once inside the abdomen, the next step is a systematic exploration to identify the exact site of the perforation. The examiner expects you to locate this defect on the anterior aspect of the duodenum, known as D1. This sets up the core operative question of the viva. What are you going to do? You satisfy the rubric's first requirement by stating you will close the defect by suturing with an absorbable suture. You must detail the crucial addition of an omental patch, known as Graham's patch. The repair mechanics require placing interrupted sutures across the duodenal defect. A pedicle of well-vascularized omentum is brought over the perforation and secured firmly without tension. Detail a critical pitfall to the examiner here. Warn them that taking massive tissue bites with your sutures risks stricturing and narrowing the duodenal lumen. Once the physical repair is articulated, pivot your discussion immediately to the concept of source control. You must vocalize the need for aggressive, systematic peritoneal lavage. The goal is to physically clear the massive chemical and bacterial loads from all four quadrants of the abdomen. To secure the final points for intraoperative management, state that you will place targeted drainage and perform a standard abdominal closure. Consultant-level operative management requires executing a tension-free, physiologically sound patch and achieving absolute environmental source control to prevent post-operative sepsis. The operative station does not end when the skin is closed. The examiner will prompt you for a comprehensive post-operative care plan. List 3 supportive measures for full points: nasogastric suction, continued IV fluids, and adequate analgesia. Next, detail the required pharmacological interventions, a regimen for eradicating H. pylori, and a proton pump inhibitor. The clinical rationale for these medications is clear. High-dose proton pump inhibitors and H. pylori eradication treat the underlying etiology of the ulcer and are critical to preventing a recurrence. Regarding diet, adhere to the strict rubric parameter. Oral intake will only resume when there is clear clinical evidence of returning bowel function. Executing this comprehensive plan demonstrates the ability to manage the patient's underlying gastrointestinal disease alongside the surgical repair. The final high-level hurdle of the viva is anticipating and categorizing specific surgical morbidities. We can organize the 7 rubric complications into a fault tree diagram. The immediate physiological complications you must expect are paralytic ileus and severe electrolyte imbalances. Under the site-specific or anastomotic branch, you must list intra-abdominal collections and a duodenal fistula. A duodenal fistula is the direct result of a technical failure of your Grams patch, almost always caused by unrecognized tension on the repair. Finally, complete the diagram with the delayed wound branch, listing wound infection, incisional hernia, and adhesive intestinal obstruction. Passing this viva station requires executing a strict tripartite formula: rapid protocol-driven resuscitation, precise algorithmic surgical repair, and the comprehensive anticipation of systemic morbidity.